Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Vasilis Igmenov from Germany. Dr. Igmenov is the Chief Medical Officer at the Spine Center Medius Clinic in Nottingham, Germany. Vasilis completed his orthopedic residency from the Ethicon University General Hospital in Athens, Greece, before moving to Germany. He currently serves as the Vice President of FORT, which is the Federation of Orthopedics and Trauma Trainees in Europe. Dr. Vasilis is also a PhD candidate at the University of Athens. So today it's my great honor to introduce you to Dr. Vasilis Igmenov from Germany. Over to you, Vasilis.
Thank you very much. First of all, I want to say that I'm very honored for this invitation and to be with Professor Gopalan here to tell some things about the metastatic disease of the cervical spine. Thank you for having me here, and it's a really honor to be here. Let's go to this subject. I would like first of all to say that I'm a spine surgeon. My name is Vasilis Igmenov, and I am of orthopedic origins. So actually, we will concentrate more on the surgical management of these patients, because we cannot expand to the whole spectrum of the management in one talk of the management of the spinal metastasis. But we will say some things about the non-operative management. So the spinal column represents the third most common site for distant metastasis after lungs and liver, and is the most common site for metastasis within the skeleton. Patients with cancer will develop eventually symptomatic spinal metastasis in 10% of all cases. Of these lesions, about 8 to 20% can be found in the cervical spine, and the upper cervical spine is affected in less than 1% of cases. Most commonly, as said, we have metastasis from breast, lungs, and the prostate. So the management of spine instability comes more into focus not only because we have more patients we have a high incidence of these patients, but also because we have a markedly increased overall survival in patients with cancer due to ongoing developments and improvements in oncology. So we will eventually, as an orthopedic surgeon or a spine surgeon, most of surgeons will come across these patients. We surgeons love to hate classifications. So I have to tell some words about classifications. We have plenty of them. However, which of them are of practical use? The most known are the Tomita, the Tokuhashi classification systems, which can give us a direction. However, from this nice paper from Hibbert and Kwan from Australia, it was shown that although some of these classifications may do better than other in some points, however, these are more useful and not so useful for the stratification of survival of prognostic groups. And having said that, the Memorial Sloan Kettering Cancer Center actually introduced the idea of a multidisciplinary approach and introduce actually the classification of NOMS, which is a classification that it does not actually have points or scores, but it says actually to us that we have to treat this patient through a multidisciplinary approach. We have the neurological status, the oncological status, the mechanical, where we have spinal instability, and the systemic status of these patients. Spinal instability, this is something that actually has to do with us surgeons, because we will have to answer to the question of if this patient that we have in front of us has an unstable lesion that has to be surgically treated. So what the spine oncology study group says about spinal instability is that it is actually the loss of spinal integrity as a result of a neoplastic process that is associated with movement-related pain, mechanical pain, symptomatic or progressive deformity, and or neural compromise under physiologic loads. I find this score very useful for the daily practice, and many surgeons use this score, the Spinal Instability Neoplastic score, that it was introduced some 10 years ago, and actually is very helpful to, if you have a score below 7, someone can say with more safety that this patient may not require surgery. If you have on the other side a score that is above 13, then this patient has to be treated surgically. But this is not 100% certainty. Why? Because we have another approach which is very similar to the NOMS approach, which is the LMNOP system that was introduced from Fernie and Ivanis really from Canada. And this system actually incorporates, apart from the NOMS classification, also the L, the location. So we have location, we have mechanical stability, instability, neurology, oncology, and instead of S, we have the letter P that stands for patient fitness, prognosis, and patient's wishes and overall status. Why did I tell all these things? Because actually we have to fully understand that these patients require a multidisciplinary approach. And this is something that this paper that was published in Lancet Oncology shows us a very complex algorithm. However, you can see here on this side that yes, spinal stability plays a very significant role, because if you have an unstable fracture, an unstable pathological fracture or a stable situation, you have to surgically stabilize this patient. However, there has to be this patient. There are some prerequisites. If you have a patient that has a very low performance score and a very low prognosis that is less than 2 months, then maybe we should head to more palliative measures, and we should not go to surgery. This is a very important prerequisite: patient's prognosis and overall status. I will pause now a little bit the theory, and I will break up the theory with this case. This is a patient with multiple myeloma. He was admitted in our clinic 3 years ago. He was admitted not due to pain or neurology. He had to have a normal a cycle of chemotherapy. He remained in the hospital a couple more days because of some other nausea or something like that, like after the oncological treatment. During his stay in hospital, very early in the morning, he developed a paraparesis. And this CT is actually a routine CT that was done prior to his paraparesis to show they did it to find to stage actually the disease. And you can see here that this patient has actually nice round lesions with sclerotic margins. We don't have any cortex breach. However, this patient, he developed the paraparesis. The MRI that was done a couple hours afterwards showed that this patient has had these two simultaneously epidural spinal cord compression sites, one on the level C47 and the other on the level T5 to T12. So many of you may think, yes, of course, we have to do the surgery. However, this was not always the case. There have been many treatment modalities, and the problem with the spinal metastasis patients is that we don't have vast data and concrete data. We didn't have actually. So this group of patients is very heterogeneous, and there have been patients that have been treated with radiation therapy, and there are some patients that they are still maybe treated with radiation therapy, presenting a paraparesis. We have to have concrete data. The decision upon the optimal management for these patients should consider the life expectancy. It has to be more than 8 weeks or 2 months, the tumor pathology, the stability, as I said before, the neurological status, and the severity of pain. Why? Because actually the indications for surgical treatment include intractable pain resistant to non-operative management, spinal instability, and neurological deficit. Not all patients with spinal metastasis will present with paraparesis. Most of them will have actually the first symptom here, which is the intractable pain. There have been some weaker indications proposed also in the literature, like progressive deformity and malignant process with obscure primary site. But these were the primary three indications: pain, instability, and or neurological deficit. The goal of surgery is to resect, if possible, the cervical metastasis, to decompress the myelin, followed by reconstruction in order to do what? To restore the function and quality of life of patients. Back to our patient, he had this epidural spinal cord compression. What we did a spinal fusion from C4 to C7 and T5 to T12. The patient did very well. Actually, the day after surgery, he was able to stand up. And 1 year later, you see here, 1 year later, he had a residual bladder control deficit. That was actually not a major problem when comparing to a situation that he would be lying in bed and perioperative. So this patient was very lucky, actually, because he developed the paraparesis in a hospital setting, and he was led to surgery very fast. I said previously that this was not always, however, the case. This is a landmark paper from Lancet from 2005 from Roy Patchell. And this is actually the first RCT, a multicenter RCT that compared radiation therapy and radiation therapy with surgery. And the results were that decompressive surgery with radiation therapy is superior to treatment, is superior to treat patients as compared to radiotherapy alone. After that, we had a few more studies like this meta-analysis that where we have reported ambulatory success, a markedly higher ambulatory success to patients treated surgically. And more precisely, we have most surgical papers reporting twice more often that patients were able to regain ambulatory status. So this is very important. And also in the surgical papers, patients that could still ambulate after that were ambulatory before surgery and could still ambulate after therapy, they were also markedly higher as compared to radiation papers. About the cervical spine per se, here we have also the similar results where surgery with radiation therapy is found to be more effective in treatment in terms of neurological recovery and pain control. A few more studies stating these facts, that radiotherapy alone does not offer much as compared to surgery in patients with neurological deficits. Here we see, for example, that paraplegic patients had a 4-fold greater recovery rate compared to radiotherapy alone. And I don't want, however, to pass the message that surgery is the only solution and the only viable solution. Nowadays, we have evolved techniques, we have MIS, and we have also the stereotactic radiation therapy, which have greatly added to our weapons when we treat patients with cervical, with spinal metastasis and cervical spinal metastasis. In this review from 2018, for example, MIS was not found inferior compared to open surgery. However, generally we have results that are mostly level 3 and level 4, so we can trust them, but we cannot completely be based on them. Of an undoubtful advantage of MIS is that after MIS surgery, we can initiate even 1 week after surgery with radiation therapy and other treatment modalities. Whereas with classic surgery, we have to wait for the wound to be fully healed, and then we can initiate. That means maybe 3 or 4 weeks later. This is very important, and this is a very strong advantage. If we combine, however, MIS with stereotactic radiosurgery, then we see that we have a reduced morbidity and fast operative recovery by creating a corridor between the tumor and the spinal cord. What does this mean? This is actually the separation surgery. I will talk about it in a few seconds. With the improvement in radiation therapy, and we have radiosurgical doses that are more effective for local control, while carrying a certain risk of complications, which is lower compared to traditional radiotherapy. What is separation surgery? It's actually the spinal decompression, where we create an epidural, a corridor, and 2 to 3 millimeter epidural margin between the dura mater and the tumor, which is enough to deliver safe and ablative doses of stereotactic body radiation therapy to the vertebra. These patients, we have to think more globally and more multidisciplinary. These patients are frail. So in general, the concept that we have to move towards MIS is very right. And if we combine these MIS techniques with state-of-the-art radiotherapy, then we have very nice results, like this published very recently in a phase 2 clinical trial, where separation surgery followed by stereotactic radiation therapy gave very promising and very good results. About carbon, some of you may have heard about these carbon materials. These are new materials, have been used for the past 4 or 5 years. Actually, we don't have an implant that is ideal. However, here the undoubtful advantage of these implants are that they have less artifacts and they can allow for better radiotherapy planning. I don't have a personal experience with these implants, so I will say to you what the literature says. They're not found to be that inferior. However, we have to wait about long-term studies. And I will show to you some patients of ours that were treated some years ago. We studied these patients. It's about 24 patients. And I will give you also the characteristics of patients with cervical spine disease, because up to now we have talked about spinal metastatic disease, and we have talked about some things about cervical spine metastasis. Now we will go a bit more concentrated to this to this subject. As expected, most of these patients had a metastasis after lung adenocarcinoma, followed by breast, prostate, and renal clear cell carcinoma. Most of these patients have at least 2 skeletal lesions, and half of them, you have to consider that if you have a patient with spinal metastasis, most probably they will have another lesion below or above the metastasis you have found, and most of them have another metastasis, visceral metastasis. There are very few patients, those that present with a solitary bone metastasis on the spine. The atlantaxial spine is more rarely involved. And something also interesting is that these patients that present with cervical metastasis, many of them, and this is also according to literature, literature says about 30 to 50% of these patients, the first symptom of their disease is the pain on the cervical spine, or a radiculopathy or myelopathy after the metastasis. They don't have any idea, many of them patients, and this is this means that we have to improve our means of diagnosis and our treatment modalities. They have, as I said, an improved median survival. It's more than a year for most of these patients. And of course, it depends on the primary tumor. The most clinical presentation in patients with cervical spine metastasis is pain. And this pain is actually non-mechanical in contrast to other patients who have a mechanical pain, because the lumbar spine, for example, has many loads, and there you can find more patients with mechanical pain. In the cervical spine, we have most frequently non-mechanical pain that is presenting during night or a day and doesn't have to do something with movement. The second symptom is neurology. In these patients, we had about half of the patients had about metastatic epidural spinal cord compression with neurology. One patient had quadriparesis, one hemiparesis, two with paraparesis. I'm sorry. And weakness generally can be found in these patients in 60 to 85% of this patients. So neurology is more frequent there when compared to other lesions in the spinal column. Loss of working ability has devastating effects. We have to take that very seriously into consideration. The outcome is better if treated early. Within 2 weeks after onset is a very good and safe time. This patient is not lost, even if he has. We have still to try to regain what is there. Of course, ability to walk at the time of diagnosis is a significant predictor of outcome. Of our patients, for example, many patients improved in terms of ASIA score, and of these that were non-ambulatory, two improved to, and they could ambulate after surgery. Mean hospital stay for these patients is relatively long, so you have to they have to stay 7 or more days in the hospital. And these patients, regarding surgical risk, are ASA, ASA 3 or maybe 4 most of the times. Blood transfusion can be required, but mainly for cases that are done from posteriorly. So you have to be prepared to deal with a medically high demanding group of patients who have severe or extreme systemic disturbance. However, acceptable rates of mean hospital stay, ICU stay, and blood transfusion units can be accepted. It's very important to have a careful wound inspection, always prior, and this has to be always prior to the commencement of radiotherapies and chemotherapies. We didn't do any myelin invasive, so in our protocol was a 3 to 4 weeks postoperative time. Some cases, this is a case with C2 with a dense metastasis, a previously unknown lung adenocarcinoma. This patient had a 4-month survival. We do this stabilization with which is a hybrid with hooks and transarticular screws to avoid the occiput to C3 or C4 stabilization. This is more elegant, requires navigation, because you have to think of the artery that can be injured if not done under navigation. Another case, a C5 corpectomy, lung adenocarcinoma. We did stabilization and corpectomy from anteriorly. Also, similar case, C6 corpectomy, and I would like to show you now and some complications. We have, of course, there are some complications. Most of them are regarding to wound dehiscence, spinal instability. We have also reported in the literature pneumonic emboli and deep vein thrombosis, pneumonia, urinary tract infection, respiratory failure, and in our case we had an intraoperative injury of the left vertebral artery C2 that was treated with tamponade intraoperatively. Another complication, this can also happen because this patient was operated from posteriorly for the metastasis on the level of C2, and then he was also treated anteriorly for the other metastasis on the level of C6. what the patient developed this kyphosis after surgery that was treated with a revision surgery to C0, and this patient could not swallow due to this kyphosis, and of course he remained stable, but not being able to swallow or to stand was a problem. So in terms of palliative treatment, someone can also perform this type of surgery. Again, these transarticular screws that had to be revised to a C0 to C3 dorsal fusion. Complications, according to literature data, as I said, there are about 10 to 30%. DVT, pneumonia, hardware failure, also cerebrospinal fluid leak. But when timely and properly managed, complications do not constitute a major burden and should not, they should not actually make us worry or afraid of the surgery, because if these patients are properly informed and followed closely, then these patients will be will gain will earn a lot of the surgery. It's a palliative surgery. We have to keep that in mind, so we don't have to do heroic surgeries. These patients have to have a prognosis of at least 8 weeks, 8 to 12 weeks. Again, literature is a little bit here, but at least 2 months. Let's take this as a time limit. Radiation therapy, chemotherapy, and vertebroplasty have yielded satisfactory results, yes, but if you have patients with neurological deficit, spinal instability, or deformity, then the duration of their effect is rather questionable. What about the choice of the technique? And I will finish slowly my presentation with that. As I said, it is a palliative surgery, so unblocked resections are not generally recommended in this area, even if deemed feasible. Even if someone is a very talented surgeon, they don't have to do such a surgery because it is a palliative surgery. The cervical spine, although quite short, has some differences in the upper cervical spine, in the subaxial spine, and in the cervical thoracic junction. So we generally propose this, and this is also something that can be found in literature, that for the upper cervical spine, a standalone posterior technique is sufficient. The spinal canal there is very. We have almost. We don't have any neurological deficits, and we don't have to be afraid of a metastatic epidural spinal cord compression on the level of C1 or C2. So a standalone posterior stabilization is a very good operation, a very nice operation for these patients. For the subaxial spine, the gold standard is from anterior and may be combined with a posterior approach if we worry about stability. But from anterior, we can resect the vertebra and stabilize it much better. Not the whole vertebra, but a hemicorpectomy or something like that. And for the cervical thoracic junction, we recommend the posterior approach, but it depends also on surgeon. There have been some papers that they treat also that from anterior. We think that the posterior approach with a decompression is very effective and can be carried out with safety. Regarding the cervical spine, if you have a navigation, you can use the pedicle screws with more safety. Of course, in freehand technique, you can do the pedicle screws, but it's a bit risky regarding the artery and the roots. So if you have a navigation, when you use pedicle screws, you can do longer screws that can hold much more loads. Therefore, you can spare some segments and you can keep it as short as possible. In conclusion, I would say that these patients require a multidisciplinary approach, and if they are appropriately selected, they can greatly benefit from palliative surgery. They have a very good survival compared to patients with metastasis, with skeletal metastasis or spinal column metastasis 10 or 20 years ago. And the long-term satisfactory outcomes with respect to pain relief and neurological improvement are very good. Patients of poor general condition with neurological deficits lasting days or weeks should be expected to benefit the least. Regarding ICU stay, intensive care unit stay, and intraoperative blood transfusion, there we have acceptable rates there. A wide unblocked tumor resection does not consist of a prerequisite for palliation and can be avoided. And a single posterior approach for the majority of lesions locating at the cervical thoracic junction can be performed with very good outcomes. That was what I want to say to you, and I want to invite you also to invite the residents and trainees to the summer school that it's going to take place in Athens this year. Thank you very much.
Thank you, Vasilis. Vasilis, you can stop sharing. Thank you, Vasilis, for this very comprehensive presentation, and congratulations for the excellent work that you do in Germany.
Thank you. It is a teamwork. It is a teamwork, and this is the message I try to pass through my. It's not only the surgeon; it is the tumor board. Actually, the tumor board is responsible for these patients because you have to sit down with the oncologist, with the radiation therapist, with the internists, and you have to reach a decision because we may see we may see a CT scan and say, or an MRI and say, oh, we have to go to surgery right now. But if the patient is not fit, or if the patient, there are many factors that have to be taken into consideration.
Thank you, Vasilis. Vasilis, have you used vancomycin into the surgical wound to reduce the infection rates? Do you use it routinely?
Routinely, no. But the most worrying part regarding I had some wound dehiscences in the cervical spine, not in the lumbar or thoracic, because the posterior approach may lead also to greater wound dehiscences and infects. So if I see that if I know that the patient will receive radiation therapy afterwards, or if we feel that the skin is not that of great, more not to prevent the infection, but I've read a paper about vancomycin, and actually there are many colleagues that use it like a substitute to facilitate the wound healing, because as a powder it can facilitate and enhance the wound healing, not as an antibiotic that can because we don't have any studies actually on that, on these patients, also in spine, but on these patients we don't have any studies saying that yes, you have to do it because the infection rates are lower.
Thank you, Vasilis, for that. And Vasilis, one of your x-rays, you showed a renal cell carcinoma that got metastasized to the cervical spine, right? So these are highly vascular tumors, right? So do you use preoperative embolization to reduce the burden?
Very nice question, Hitas. I didn't mention that because I would like to have a conversation with, and I would bring it up. Yes, actually, the embolization is a very good solution for these patients with renal cell, and we have done it also to 2 patients after the oncologist told us that in 2 patients with thyroid cancer, we had to do the embolization. And I will, from personal experience, I will tell you that I've seen on the table patients operated without embolization. The difference is enormous if you do preoperative embolization, but the problem is that it has to be very well organized, because they don't, if you do it now and do the surgery a week after, it doesn't play any role. It has to be within the time frame that the radiologist gives you, which is 24 maybe to 48 hours.
Thank you, Vasilis. And Vasilis, you mentioned also about stereotactic radiosurgery, right? So that is something that has a huge potential. And do you use it in your hospital? Do you have stereotactic radiosurgery available with you?
In this clinic where I'm now, no. But it is not that broad. It's not. It cannot be so easily found everywhere. But again, if we think that the patient, if the tumor board thinks that the patient will benefit from that, then it will be arranged to go to another center, bigger center with oncological center with this type of
And do you think there are any contraindications? For example, there's an epidural extension of the tumor. Do you think SRS would work?
Actually, the data say that I don't have personal experience, but the data says that when combining with a very small decompression there, these patients have very great results. Also by patients, according to literature, that had radio-resistant tumors. And this is very important. Tumors that have been regarded as tumor-resistant with stereotactic can be dealt successfully.
Thank you, Vasilis. Vasilis, just one last question before we wind up the session. I was just looking into one of the papers by Michael Fellings in Spine 2009. And interestingly, what he said was a 3-column approach towards using a single posterior approach.
Yeah,
the cervical spine. There is more and more papers being published and more and more surgeries being done. So do you think a 3-column approach should be done?
For cervical, I was speaking about the cervical spine or the thoracic spine?
Cervical.
Actually, the 3-column approach, I'm not. I mean, Michael Fellings has such a big experience, and I cannot. I know what you're speaking about. The problem is that if you do it in 2 times from anterior and posterior, and not everything from posterior, I think it's more elegant as an approach, because from the anterior you don't have any bleeding. Actually, if you do also the preoperative embolization, you don't have any bleeding, and you can do everything perfectly with no danger, and then you can do a minimally invasive also from the posterior. You can do some screws. I wouldn't do that from posterior only. A 3-column approach, yes. If you have a major issue of stability, if someone does a corpectomy, a 2-level corpectomy, C5, C6, then yes, we have a major issue of instability. Then maybe, most probably, we have to go also from posterior. I would do it in 2 settings: first from anterior, and then from posterior, some screws, and not everything from posterior. I wouldn't do it.
Thank you, Vasilis. Vasilis, I think that's all the questions that we have for the session. Thank you for this very comprehensive presentation.
It was a very nice discussion. Thank you for your questions. It was great.
Thank you. Bye-bye.
Bye-bye.